Hello, I'm Ann Sosa. I'm an endocrine surgeon and surgical oncologist and have the privilege of serving as the chair of the Department of Surgery at the University of California in San Francisco. So appropriately, I have a Zoom background with the Golden Gate Bridge, which is very near where I live and work. And of course, on my first slide, there's a seismograph because earthquakes are not uncommon in California. I'd like to thank BJS for the privilege of giving an extended version of this lecture to the European Society of Endocrine Surgeons in 2024 in Rome. And I look forward to sharing with you today a snapshot of both the current landscape as well as insights into shifting paradigms in the management of differentiated thyroid cancer. These are my disclosures, and they have no relevance to the content of this discussion today. They pertain to medullary thyroid cancer, and I'll be restricting my conversation to differentiated thyroid cancer. Well, when I'm not operating or talking about operating, I love to read. And one of my favorite authors is Adam Grant, an organizational psychologist at the Wharton School of Business in Philadelphia, Pennsylvania. This was the book he wrote during the pandemic, Think Again, and it's really interesting book, a book about change and change management. And one of my favorite quotes from that book is, once we hear the story and accept it as true, we rarely bother to question it. And perhaps that is why so many of us are averse to change. But in fact, I think to be able to be successful surgeons, endocrine surgeons, and scientists, we need to embrace change when change is informed by evidence. And the focus of my conversation today is the kinetics of thyroidology and thyroid cancer and how to manage change in this field. So this is the epidemiology of thyroid cancer in the United States over the last 30 years. We've experienced, I used to say pandemic, and then that word was borrowed to describe infection in the world. So I've gone to using the word epidemic. There was an epidemic in the United States of thyroid cancer with an increase in incidence of the disease of more than 300%. Over 30 years, it impacted all demographic subgroups in our country. And it's interesting that similar observations have been made in virtually every developed and developing country around the world. So the question is, what was going on? And it's amazing when you turn to the literature how thin that literature is when you actually do a deep dive. And there was really just one pivotal study published in JAMA in 2006 by Welch and Davies, striving to explain this phenomena. Let's walk through the critical figures from that paper, starting in the upper left-hand corner, where you see that papillary thyroid cancer, a single histologic subtype, a differentiated thyroid cancer, appears to be the engine of this rise in incidence. In the upper right-hand corner, you see it appears to be the smallest tumors, less than 1 centimeter in size, which we call papillary thyroid microcarcinomas, that appeared to be driving the change. And then perhaps the most famous, but the most controversial figure from that paper here in the middle, where you see that rapid rise in incidence of thyroid cancer superimposed on a figure that shows stability in mortality, leading the authors to conclude that we believe increased diagnostic scrutiny is the most likely explanation for the apparent increase in incidence. That is, that this phenomenon is all an artifact resulting from overdiagnosis. Well, I think all of you are familiar with this figure, the iceberg, where only a little bit of the iceberg is above the surface of the water. Most of it is below the surface, leading us to postulate that the whole truth is often hidden from view. And certainly this was a question that occurred to me when I read that Welch and Davies paper many, many times. I got stuck on that final figure. In green, rapid rise in incidence, a very large number in the United States, on the order of about 45,000 new cases of thyroid cancer diagnosed every year. Fortunately, an indolent disease where there is a paucity of death, a good thing for patients. So a very small number here. And the big number and the small number are superimposed on an arithmetic y-axis, raising to me the question of, is it possible that this arithmetic scale is disguising motion in the mortality statistic? Now, I'm not a biostatistician or an epidemiologist, but fortunately I have friends who are, so I called up an epidemiologist at the National Cancer Institute, Kari Kitahara. I sent her the primary data and I said, can you take these two lines and put them, instead of on an arithmetic scale, on a semi-log scale? This now appears on the right. And just with that, we may come to different conclusions. And this figure was published subsequently in Nature Reviews. And what you see on this semi-log scale is this rapid rise in incidence, unchanged from here. But now you see something that should raise our eyes, and that is mortality is not flat, but rather mortality appears to be increasing with an annual percentage change of 0.8%. And with this signal, we, and perhaps you too, can write a paper that is published in JAMA. And this was the subsequent manuscript published in JAMA in 2017, where essentially we replicated the Welch and Davies paper that went before, but we made two critical changes. The first is that instead of using mortality as one of our outcomes, we used incidence-based mortality. Why? Because incidence-based mortality is a better outcome when there is a paucity of that outcome, which of course there is for mortality when we speak about thyroid cancer. And secondly, we changed how we presented our data, and instead of using arithmetic scales on our y-axis, we use semi-log scales. We replicated the Welch and Davies study in that we used age-adjusted rates and reported annual percentage changes determined from joint point regression analysis. And look at how our findings change, starting with incidence. So as I showed you in that Welch and Davies studies, a rapid rise in incidence in these tiny tumors, less than or equal to 1 centimeter. But what we find, in contradiction to what Welch and Davies discovered, is that tumors of all sizes, including the largest tumors, less than 4 centimeters in size, so about the size of a golf ball, increased in incidence. In the case of these very large tumors, an increase in incidence with an annual percentage change of 6.1% per year. This does not fit the explanation of overdiagnosis. And then if we turn to incidence-based mortality, rather than finding stability in mortality, which was described by Welch and Davies, we see increasing incidence-based mortality for tumors of all sizes, including the smallest tumors, those less than or equal to 2 centimeters, with an annual percentage change of 6.8%. Again, this does not fit the hypothesis that it is all overdiagnosis. So while we agree that overdiagnosis is part of the explanation, it cannot be the only explanation for rising thyroid cancer incidence. And ultimately, I think we are doing our patients a disservice if we distract resourcing away from research in the arena of thyroid cancer. Clearly, improvements are needed in how we manage patients with thyroid cancer, and especially with those with advanced stage papillary thyroid cancer. Well, should we be wringing our hands? On the contrary, I think that with really good evidence, we can inform practice change and turn things around. And in fact, over the last several years, we have seen a flattening of the curve, again, borrowing terminology used to describe the pandemic, and you see this rise in incidence now plateauing. And I think it's because we have changed the way we manage patients. We now have evidence-based guidelines that have recommended higher biopsy threshold, eliminating that part of the explanation related to overdiagnosis. In the United States, the U.S. Preventative Services Task Force now recommends against screening asymptomatic adult patients for thyroid nodules and thyroid cancer. And ultimately, we've also changed our lexicon, going from calling some things that were formerly cancers, the encapsulated follicular variant of PTC, to using terminology like NIFT-P. So we can make a difference when we use evidence to inform change. And where are we today? Ironically, where we are today in some ways resembles where we are many years ago. So what goes around comes around. But in the end, I think guidelines are really important when they are informed by evidence. Guidelines have become a cottage industry, and virtually every professional society has a set of guidelines. And when it comes to thyroid cancer, I have had the privilege on behalf of the American Thyroid Association to co-chair the current committee that is assembling the next iteration of guidelines that actually will be published later this year in 2025. I'd like to sort of focus the rest of my presentation on these guidelines to give you a preview of what they are likely going to look like. I do want to emphasize this is a preview. These guidelines are undergoing peer review and are still in draft form, but I think there is a lot to learn and to anticipate. So I'm co-chairing this task force with Matt Ringel from The Ohio State University, who's an endocrinologist. I'd like to highlight the importance of transdisciplinary care for patients with thyroid cancer, and we have representation from many disciplines, including endocrinology, surgery, pathology, for the first time, long overdue, nuclear medicine, for the first time, a genetics counselor, a medical oncologist, and again, long overdue, a patient advocate representing the patient perspective. Finally, we have added a methodologist to our team because we've actually done some primary science, and we have published that science to inform these guidelines. I'd also mention that this is an international task force with international colleagues. This is Dr. Ringel and me, and these are our surgeons. Two are endocrine surgeons trained in general surgery. Two are otolaryngologists. So we're striving for equity to give a more balanced perspective. One of the novelties of these guidelines is that we are focusing on the patient journey. So they are assembled in order to reflect how a patient travels through their clinical pathways, starting with a diagnosis of thyroid cancer. So thyroid nodules, formerly part of the ATA guidelines, have been pulled out, and they will be published separately from these guidelines. So this is the data framework, data D, starting with the diagnosis of thyroid cancer, moving into the first A, assessment of risk and benefit for alternative management strategies with differentiated thyroid cancer. That could be treatment, either with surgery or with ablative therapies, or it could be active surveillance. In the postoperative setting, we call that monitoring. And then the final A, assessment of response, the patient's response to that treatment, whether it is active surveillance or surgical or ablative technique. We have evaluated the quality of the evidence underpinning our recommendation using the modified grade system. In this system, there are only two different strengths of recommendation. Those are strong or conditional, so that is binary. And these two strengths of recommendation can be combined with any certainty of evidence extending from high down to moderate, low, or very low. There is also a good practice statement category where the above grade criteria are not applied. When we use a good practice statement, this requires 100% consensus of opinion across all of our task force members. Well, I think the best way to understand guidelines is to apply guidelines, and we're going to walk through a real clinical case. We don't have time to go through all of the guidelines. I think there are more than 80 recommendations, but I'm going to focus on some of the most important ones and definitely some of the most important ones for surgeons. So we're going to start with a 33-year-old woman who notes some neck mass. She has no other symptoms, and she is biochemically and clinically euthyroid. She has a thyroid ultrasound, which demonstrates in the left lobe a 2.5 centimeter nodule, palpable and spongiform. In the right lobe, a smaller nodule, but more worrisome one, 1 centimeter with calcification, irregular borders, no posterior invasion, and it is hypervascular. There are no pathologic lymph nodes in the neck. FNA is performed of the smaller nodule, and it reveals papillary thyroid cancer. The larger nodule appears to be classically a benign thyroid nodule. So, turning back to 2015 and the American Thyroid Association recommendations, the recommendations are that really thyroid lobectomy is the principal intervention when a patient has a 1 centimeter papillary thyroid carcinoma. But often neglected when people read those guidelines is this 2-letter word, if surgery is chosen for these patients. And the intention of our adding in 2015 the word if is that it opened the door a crack to potentially permit active surveillance as an alternative to thyroid lobectomy. Well, here is a preview, a draft recommendation for what we think will be published later this year, Recommendation 11. And this does represent a significant change from those 2015 recommendations in that we are saying active surveillance may be offered as an appropriate management option for some patients with papillary thyroid microcarcinomas. Shared clinical decision-making between the patient and clinical team regarding risks and benefits of this approach is essential. And I will say shared decision-making is an important theme that runs across all of our 2025 guidelines. We anticipate that this will be a conditional recommendation based on low certainty evidence. So you could say, well, active surveillance now potentially being put on a par with upfront immediate surgery. What are the data to support this practice recommendation change? So I explained to you that we have a methodologist on our task force, and we published this meta-analysis systematic review looking at active surveillance versus thyroid surgery for very low and low risk differentiated thyroid cancer. This study was published in 2022 in the journal Thyroid. We started with 719 studies in the literature. Then, using a number of inclusion and exclusion criteria, we ultimately were left with only 18 robust studies reported across 27 publications. And the literature search extended from 1946 to 2021. So I said 8 cohort studies were included, and those enrolled nearly 74,000 patients. 1 cross-sectional study was included, and 6 uncontrolled treatment series were included. Sadly, 5 studies were rated fair quality, and the others were rated poor quality. And again, this is a theme that we see across the thyroid cancer literature, not a criticism of the scientists, really just an opportunity for us to continue to focus innovation and discovery in this field. Patients with low risk, primarily papillary thyroid cancers that were small, less than or equal to 1 centimeter, who underwent active surveillance versus immediate surgery, we found that both treatment strategies were associated with similar low risk of all-cause or cancer-specific mortality, low rates of distant metastasis, and low rates of clinical recurrence. In those patients who underwent active surveillance, there were rates of tumor growth that were low, and rates of subsequent surgery varied, and almost always were due to patient preferences and anxiety. They did not experience progression necessitating a crossover from active surveillance to surgery. Rather, patients expressed the preference to do that because of anxiety. As a result of all of these things, strong conclusions were impossible due to limitations of study design and quality. Clearly, more research is needed in this field. So in the case of our patient chose to undergo active surveillance as her preferred strategy. Next, we get to assess. How do we assess response and treatment? So we are right here at active surveillance, which she prefers to undergoing upfront surgery. So the question is, how should we conduct active surveillance? So this is the draft recommendation number 12. For patients undergoing active surveillance, neck ultrasound should be used to monitor disease progression, a good practice statement. And recommendation 13 draft, for patients undergoing active surveillance, routine measurement of serum thyroglobulin and or antithyroglobulin antibodies is not recommended. That's a conditional recommendation based on very low quality evidence. And finally, draft recommendation 14 that applies to this patient. In patients undergoing active surveillance, surgical resection is indicated if there is evidence of new biopsy-proven lymph node metastasis, growth by more than or equal to 3 millimeters, the development of distant metastasis, evidence of extrathyroidal extension, posterior growth, or when there is patient anxiety and or express preference for surgery. That is a good practice statement. So these are the indications when active surveillance should be terminated and the patient considered for a surgery. So in this case, our patient chose active surveillance as her management strategy, but after 2 years of monitoring, there was nodule growth by 3 millimeters from 1 centimeter to 1.3 centimeters in greatest dimension. The patient was anxious about monitoring, and so surgery was planned. So the next question is, what surgery should be performed? So according to the ATA guidelines published back in 2015, the initial surgical procedure could be either a bilateral procedure, near total or total thyroidectomy, or a unilateral procedure, thyroid lobectomy. And so overall, it was believed at that time that there was evidential equipoise, and either lobectomy or total thyroidectomy could be pursued. There were some more specific indications for total thyroidectomy that were described, and that was a strong recommendation based on moderate quality evidence. Well, things are anticipated to change later this year with regard to extent of surgery for low-risk differentiated thyroid cancers. Here's draft recommendation 15A. When resection is performed for patients with thyroid cancers less than or equal to 2 centimeters without gross extrathyroidal extension and without metastatic disease, the initial surgical procedure should be thyroid lobectomy, unless there are bilateral cancers or other indications to remove the contralateral lobe. A strong recommendation based on moderate certainty evidence, so a shift from evidential equipoise for either surgical strategy and a move towards a preference for thyroid lobectomy. Why is that? That is because thyroid lobectomy is seen to have superior short-term outcomes with equivalent long-term outcomes, i.e. survival, when compared to total thyroidectomy. Well, what about those tumors between 2 and 4 centimeters in size? This is our draft recommendations for those, not this patient with a 1.3 centimeter tumor, but at a population level for patients with low risk unilateral thyroid cancers 2 to 4 centimeters. Thyroid lobectomy may be the preferred initial surgical treatment due to significantly lower risk and side effects. So a less strong recommendation, but still thyroid lobectomy may be the preferred option compared to total thyroidectomy. Well, do you have to do a thyroid lobectomy in either of these scenarios? And I don't think ever clinicians or patients should be restricted in their options. So this is the next part of our draft recommendation 15B. However, the patient and treatment team may adopt total thyroidectomy to enable RAI administration and or enhance follow-up based on disease features, suspicious contralateral nodularity, and or patient preferences. When lobectomy is offered as initial treatment, the patient should be counseled about the possibility of conversion to total thyroidectomy or need for subsequent completion thyroidectomy if higher risk factors emerge intraoperatively or postoperatively, a conditional recommendation based on low to moderate certainty evidence. So because the patient had that 2.5 centimeter, probably benign nodule in the contralateral lobe, the patient did prefer total thyroidectomy, and that was the surgery that was performed. So she exercised her preference. The final pathology revealed a 1.6 centimeter classic PTC with microscopic invasion, completely removed with negative surgical margins. 1 of 5 lymph nodes in the central compartment removed, had a micrometastasis without extranodal extension. So what is the staging and risk category for this patient? So she has stage 1 disease with excellent anticipated long-term survival. Based on our ATA risk stratification system, she is at low risk for residual disease or recurrence. Should we perform molecular testing of her tumor? No, it should not be performed if it has not been performed already. Why? Because it will not impact our therapeutic decisions. Well, should radioactive iodine be administered in the post-operative setting? Based on the 2015 risk stratification, she has a low-risk tumor, and the answer would be no. But how should we monitor or risk stratify this patient going forward? So you will remember in 2015, we have various response categories extending from an excellent response to an incomplete biochemical response, to an incomplete structural response, and finally, an indeterminate response informing the management recommendations that her clinical team would make. Well, let's collect data. So this patient in the postoperative setting is on LT4 replacement therapy. She has a TSH of 0.35 with a thyroglobulin level of 3.2 nanograms per milliliter, 6 weeks out from surgery. At 6 months, her TSH is 1.2 and her thyroglobulin is 0.8. Neck ultrasound shows minimal residual normal appearing thyroid tissue. So she would, based on our ATA risk stratification system, have an excellent response based on her clinical course, but an indeterminate response due to that thyroglobulin level. So the question is, how do you deploy thyroglobulin in the postoperative setting when a patient has not had a total thyroidectomy with radioactive iodine? That is, when the patient has had a total thyroidectomy without radioactive iodine or a thyroid lobectomy. Both of these clinical scenarios have become much more common in 2025, where a less is more surgical approach has been taken to low risk differentiated thyroid cancer patients. So this is the second piece of science published by a subgroup of our guidelines task force, another meta-analysis systematic review published in 2022 in the journal Thyroid and assisted by our methodologist, Roger Chu. We started that systematic review with 827 studies, but wound up with just 37 based on stringent inclusion and exclusion criteria. I just want to highlight one of the biggest problems we continue to face is the low quality of evidence that is informing our guidelines. Methodologic limitations, very serious. serious imprecision across these studies, serious inconsistency, some indirectness, leaving us with an overall quality that was very low. Well, what could we conclude? Following partial thyroidectomy, lobectomy, thyroid globulin measurement really was not accurate for diagnosing recurrence or metastasis, or estimates were frankly imprecise. Following total thyroidectomy without radioactive iodine, evidence was limited because few studies to date have been published, and there were very low rates of recurrence or metastasis, indicating simply that thyroglobulin levels were usually stable and low. So there you have it. The evidence really is too often thin, a call to assemble more evidence and do better science. Well, the studies following thyroid lobectomy, based on those studies, no thyroglobulin threshold level could be identified to define remission. Studies following near total and total thyroidectomy were mixed. Sometimes thyroglobulin levels were gathered after radioactive iodine was administered. Sometimes they were gathered before radioactive iodine was administered, and so no threshold could be identified to predict residual or recurrent disease, primarily in the setting of a lack of data for those patients who did not have I-131 in the postoperative setting. What could we conclude? There's probably a threshold range below which there's a low likelihood of residual recurrent disease. That range is somewhere between 1 to 2.5 nanograms per milliliter in the setting of a normal TSH. So these are preliminary draft recommendations. They are most robust when it comes to thinking about response to therapy in the setting of total thyroidectomy with radioactive iodine. But fewer and fewer patients with low-risk disease are having radioactive iodine administered or having total thyroidectomy. So when we look at these two columns, you see a lot less precision in the total thyroidectomy without radioactive iodine column when it comes to TG levels. And when you look at the post-thyroid lobectomy column, you really see no thyroglobulin level ranges described. And so this is really a change in guidelines. And again, remember, these are draft. Well, let's go back to our clinical case. So her thyroglobulin levels remained in the 0.1 to 1.5 nanograms per milliliter range in the setting of a normal TSH for 5 years. Her neck ultrasound, stable over 1, 3, and 5 years. And this is consistent with a continued or dynamic excellent response. Will we come to a time when we can reduce monitoring intensity? Based on the 2015 ATA guidelines, the answer was never. But in the 2025 guidelines, we anticipate the recommendation for de-escalation of monitoring for low-risk differentiated thyroid cancers, where at 5 to 8 years, there will be some guidelines provided with regard to how to think about the surgical intervention that was made, the thyroglobulin levels that are seen, and what the TSH is doing, as well as what ultrasound results demonstrate. So that is a significant change. Our patient is this one. She had a total thyroidectomy with an excellent response. She did not undergo radioactive iodine, so we would be looking unstimulated thyroglobulin levels less than 2.5 nanograms per milliliter when there are no antibodies present. She can have a normal TSH, and after that monitoring every 1 to 3 years for 5 to 8 years, potential there can be discontinuation of monitoring unless that TG level rises or her antibodies become newly detectable. So a big anticipated change there. And then finally, it's a busy slide, but I just want to highlight this. This is a very new and very important figure in the new guidelines where we are anticipating risk of recurrence based on a number of demographic, clinical, and pathologic data. Unlike the 2015 ATA guidelines, where there was only one arrow, heat arrow for all DTCs, we now will be presenting 3 separate arrows for each of the histologic subtypes, that is papillary, follicular, and oncocytic thyroid carcinoma. So a big change, hopefully one that is helpful for clinicians and patients. So where does that leave us to conclude? A lot of people have said, well, Julianne, am I hearing you say that less is always more? And I have to say, I love this figure. It's very catchy. And while I love the image, I don't think that is where we are left. Less is more only when more is too much. And those wise words were said by an American, very famous American architect, not thyroidologist, Frank Lloyd Wright. So what do I really think we're saying? I think the present and the future is around personalized thyroid cancer treatment, where we personalize what we do based on the unique clinical, demographic, pathologic characteristics of our patients, weaving in molecular testing, their mutational profile, and importantly, patient preferences based on the patient's values and their attitudes, brought together with the fund of knowledge and skill set of the clinician, and informing a shared decision-making process. The patient always should be in the epicenter of decision-making, informed by a transdisciplinary team. And when we use evidence to inform change, I think change should be embraced. Thanks to BJS for the opportunity of talking to you today.